Hello, everyone. Nice to meet you. And I'm the host, Alex. I'm the sales manager of RWD. Today, we have the honor to invite Dr. Anna Nemec to make this webinar. Dr. Anna Nemec is a veterinary dentist specializing in dogs and cats. Obtained her Doctor of Veterinary Medicine degree from the University of Ljubljana, Slovenia in 2004. She completed a residency in dentistry and oral surgery at the University of California, Davis, USA. Since 2012, Dr. Nemec has focused on promoting pet oral health in Slovenia. She teaches at University of Ljubljana and has contributed to over 110 veterinary conferences globally. Active in various veterinary organizations, Dr. Nemec has received awards in the field. She served as reviewer for international journals and also research in veterinary dentistry. Her work has been published in a lot of international journals. So let's welcome Dr. Anna Nemec to our event.
Thank you so much for this kind invitation and introduction. Welcome, everyone. It will be an evening where we dive into the topic of tooth resorption. Let me just upload the PowerPoint. Yeah, so we should be able to see it now. Okay, so we will mostly talk about resorption in cats, and because that is where we are most used to see tooth resorption. But at the end of the lecture, I will also share some rare knowledge that we have also regards tooth resorption in dogs. So what is tooth resorption? Tooth resorption is a loss of hard dental tissues due to odontoclastic activity. And that is a normal process during exfoliation of deciduous teeth. That is one of the reasons why deciduous teeth exfoliate. So it's physiologic. However, when the same type of cells are activated to start producing this resorption on permanent dentition, then this is considered pathologic tooth resorption. And you can see here, on this histological image, these multinucleated clastic cells that are literally eating away hard dental tissue. So this is tooth resorption. Tooth resorption can be internal or external. Internal would mean that it is visible on the inside of the pulp chamber or root canal walls. And in this case, odontoclasts derive from the pulp. On the other hand, what we are mostly referring to as tooth resorption, as we will talk about today, is external root resorption. And in this case, odontoclasts are activated within the periodontal ligament. And what then can happen is either replacement resorption. This is what we see again on this histological image on the right. You can clearly see this more purple area. This is dentin. This area here is actually pulp. It's void because it's very difficult to have it still in the pulp when we do our histological sections. And then you can literally see that there is no periodontal ligament between the dentin and bone. They are literally fused. So this is replacement resorption. Bone is literally replacing dental tissues. On the other hand, inflammatory resorption happens when this tooth resorption process is driven by inflammation that is present in the area, which is most commonly happening in periodontal disease. And we will see cases about this shortly. Regardless how many studies are out there, so this, what you see here, and the references are below on the slide, these are all studies looking at possible mechanisms, etiology, pathways of how tooth resorption happens. And this has been going on for now decades, and we still do not know why tooth resorption happens on adult dentition. Several mechanisms were proposed, including vitamin D signaling pathway. Nowadays, some more studies are looking into oral microbiota, activation of matrix metalloproteinases, mesenchymal stem cells, microspatial distribution of trace elements. So many aspects how researchers try to elucidate this process, but we still do know why this is happening. The fact is, though, that the disease is absolutely very common. It will affect, or we will see it in at least 1/3 of domestic cats. And in some studies, they also propose that the percentage or the incidence is much higher. And some studies suggest that about 70% of domestic cats can actually be affected. It was shown that the disease is more common in purebred cats and in older cats. But probably the risk in older cats is higher because also they have more time in life basically to develop the problem. The teeth that are most commonly affected are the mandibular third premolar and first molar teeth. So what we see here on the right is pretty typical clinical presentation where the third premolar is on the upper image, is affected with this kind of ingrowth of gingival tissue into a defect in the tooth, and the molar is just starting to have a lesion on the distal aspect. On the lower image, we see much more advanced disease where third premolar is already gone, so that's stage 5 tooth resorption. We'll talk about classification and stages. And the first molar is also, majority of the first molar is also gone, as we can see on this image below. So these are typical clinical presentations of the disease. Lesion can actually, it was believed that the lesion would start on the cemento enamel junction. That's why the old name for this disease is also neck lesion, but this is now obsolete. And it was shown that the lesion can start actually anywhere in the root and then can actually progress apically or coronally. Yeah. And what is also interesting is that even when pulp is involved, like for example, in these images I showed before, so obviously pulp is involved in this case because the majority of the tooth is gone. We can see radiographically also this huge coronal lesion with obvious exposure of pulp cavity and pulp, but yet it doesn't always, or in most instances, tooth resorption with pulp exposure does not lead to endodontic disease, which is absolutely enigmatic. It is also true, obviously, that you can see this case, which shows just the opposite. So we have severe tooth resorption of this third premolar in a cat, and we can clearly see signs of endodontic disease in this third premolar. So it's not true that tooth resorption is not associated or is not causing endodontic disease, but yet it's not that common, or it doesn't happen in all instances like it does when the tooth is fractured. So there is a different mechanism absolutely in place. These lesions are considered painful. It's always very difficult in veterinary dentistry to prove that the animal is in pain. And that is why we mostly extrapolate this knowledge from similar diseases, similar conditions in human dentistry. And it was, or it is reported from humans, that if tooth resorption lesion, because tooth resorption affects also other species, including humans. So if tooth resorption lesion is exposed to the oral cavity, so if we can feel it with a dental explorer, then these lesions or these cases are considered painful. However, if the lesion is only limited to the root, so we only see it radiographically, then it's not considered to be painful. In general, for all types of oral discomfort and pain, anyway, subtle signs are usually present when we are when the animal is experiencing pain or oral discomfort, and most of these signs of pain are related to behavior when an animal is using their mouth, either for playing or for eating or for whatever it's doing with the mouth. So when we ask clients questions about pain in oral cavity, we should always ask questions regarding changes in behavior over time associated with oral cavity use. Okay, so what can we do clinically for our patients? How will we diagnose correctly tooth resorption? So absolutely two most important things are our clinical examination. And for clinical examination, we would use Dental Explorer and run it along the gingival margin perpendicular to the tooth. By doing this, we are looking for lesions that are there. And we have to discern furcation basically from tooth resorption. So it does require a bit of practice and a bit of confidence to find the tooth resorption lesions, especially very early lesions. But using Dental Explorer is what we need to do at minimum to look at the lesions that are exposed to the oral cavity. And then if the lesion is exposed to the oral cavity, if we see something clinically, treatment is needed. Yeah. The other thing that we always need is also some type of diagnostic imaging. What we mostly do is dental radiographs. Dental radiographs are a minimum and are still gold standard for imaging in veterinary dentistry. And then on imaging, we are looking at what is happening to the roots. Yeah, and we will look into detail this a bit later. So normally we would do full mouth dental radiographs in all our patients that are first visiting the clinic to fully evaluate the health or disease of the oral cavity. It was also shown that cone beam CT, which is becoming more and more commonly used in veterinary dentistry imaging, has actually a significantly higher diagnostic yield when we talk about tooth resorption compared to dental radiography. But absolutely, cone beam CT does have its cons as well. It's certainly bigger investment when we talk about equipment. On the other hand, it's also in a way much slower, especially at the beginning when we still need to learn how to use it. And when like everything, there is a learning curve, but once we mastered cone beam CT, then it's actually much more diagnostic, or it allows for earlier diagnosis of tooth resorption as well as some other dental and oral issues. So what we need to do with our clinical and radiographic examination is to determine the stage and type of tooth resorption. Yeah. So what are then the stages? When we talk about stages, we still use the American Veterinary Dental College Association classification, and you see this classification here on the left. So stage 1 tooth resorption, it's a very, very early lesion somewhere on the cementum. And that is very difficult to diagnose clinically and radiographically. It's not actually visible. Tooth resorption stage 2, however, this one is usually clinically very well notable, and we will feel it as a lesion, as an indentation in the hard dental tissues. Tooth resorption type 2 is diagnosed when cementum, dentin, and or enamel are affected, but pulp is not exposed. Stage 3 means that majority of hard tissues are lost and pulp is involved. Stage 4 is basically majority of the tooth structure has been lost. And then substage 4A means that crown is more affected than the root. 4B means that crown and root are equally affected, and 4C means that roots are more affected than the crown. And then stage 5 is actually end stage disease, where we can only see some, we call them ghost roots within the bone, and there is no crown, no obvious dental hard tissues, and the gingiva covering the area is perfectly healthy and non-inflamed pink. These are two examples. So here on the clinical photo, we can see that the third premolar on the mandible is missing. And if we look at the corresponding radiograph, we see actually ghost roots in this area. So we will diagnose this as stage 5 tooth resorption lesion. If we look at the canine tooth, we can already clinically appreciate a lesion here on the buccal surface. So this would be either stage 2 or stage 3, or maybe even stage 4 lesion. We don't know just by clinical examination. Then we look at the radiograph and we actually see that the majority of the root structure of this tooth is practically gone. So that would be stage 4C type, stage 4C tooth resorption. On the other hand, so once we diagnose the stage, and we said that if the lesion is exposed to the oral cavity, we need treatment, yeah, then we also need to determine the type of tooth resorption, because type is the thing that actually guides our treatment. Yeah, and so-called type 1 tooth resorption means that radiographically we will clearly see the ligament around the root. Yeah. In other words, if we look at this radiograph, we can see that there is a pretty obvious lesion in the furcation area of this mandibular first molar. So that would be, for example, stage 3 tooth resorption. And if we look at the roots, we can clearly see periodontal ligament space still there. So that would be type 1. And type 1 tooth resorption is more commonly associated with periodontal disease. On the other hand, type 2 tooth resorption means that radiographically we can't really see we can't really distinguish what is bone and what is tooth anymore. This would be this radiographic image here. We can see both canine teeth with tooth resorption. And if we are looking at the roots, we can't really clearly see the ligament anymore. That is what is also called replacement resorption or type 2 resorption. And this is considered truly idiopathic because the type 1 may actually be associated with inflammation. So inflammatory process will activate odontoclasts to start resorbing the teeth. But type 2 is the one that we really have no idea why this disease is happening. And then you will also notice in the literature or on the AVDC nomenclature side that there is also type 3. Type 3, though, is nothing else than a combination of type 1 and type 2 on two roots of a multi-rooted tooth. What we also don't know about tooth resorption is how fast it progresses. So if, let's say, we decide for monitoring a tooth, when should we recommend a recheck? And we have no clear guideline on that either. And there are two examples. So these two radiographs here on top are from a cat that I saw on the left side radiograph. Is at the time when we performed some treatment in this cat, and we see that this left mandibular third premolar tooth is actually stage 5 tooth resorption, while fourth premolar and first molar look perfectly radiographically fine, and they were also clinically fine. This cat was seen 2 years later, and 2 years later, you can see that third premolar is now almost completely resorbed with actually it's stage 4, probably B, crown and root equally affected, and type 2. Mostly, there is still some ligaments on type 1 on the distal root. So it took 2 years to get from here to there, yeah? But we have no idea if that is really the case, because if we look on the lower images, on the lower photographs, this is again the same cats, 2 months difference. So when this first image was obtained when a client noted the lesion and sent me the photo. And they came in for treatment 2 months later, and you can see that the lesion is much bigger now. Yeah, so it kind of seems that in this cat here, disease progressed much faster compared to the cat that I'm having these radiographs here. So there is really no way to tell how fast the disease will progress. And if the teeth are not involved at a certain point in time, if they will become affected or not down the line. So these are all very, very gray areas. What we also don't know is if these two situations are actually the same type of disease. We said here on the right side, This smaller tooth is obviously affected by horizontal bone loss, which is a sign of periodontitis. While this tooth, the smaller here on the left image, this one is periodontally healthy, but it's also affected by tooth resorption. So are these two types of tooth resorption the same or not? Is this one driven by inflammation and this one by something that we don't know? Or both are driven by something that we don't know? These are all questions that still remain to be answered. Okay, so what can we do for these animals? Unfortunately, like with other diseases where we don't really understand the problem, the treatment is not really, targeted on that problem because we just don't understand it. What we know is that if we try to save these teeth, resorbing teeth, by means of restoration, for example, this will not help. So as far as we know, the only treatment that we can actually offer to these patients is removing these teeth. But then again, we said before that stage 5 tooth resorption, like in this third premolar here, that this is end-stage disease. So when we see these ghost roots, like an oval-shaped bone over that area, pink and non-inflamed gingiva, nothing really needs to be done. Mother Nature did what was meant to be done. On the other hand, obviously, if we have such severe inflammation, like in this case around fourth premolar tooth, with obvious resorption of the crown, taking radiographs, we can clearly see both roots. So it's type 1 tooth resorption. This has to be treated. Yeah. Another another gray zone is what do we do with lesions that we can only see radiographically? For example, this third premolar in this radiograph. So we can see pretty obvious tooth resorption on the distal root, and it's also getting towards the crown. However, examining this tooth clinically revealed no lesions exposed to the oral cavity. So by definition, we may not really need to treat this tooth at this point. But the fact is that we have no idea how fast the disease will progress, and maybe this tooth will become a problem in the next month or in the next year. So that's why these teeth that are radiographically affected but showing no clinical signs of disease are another gray zone where we just need to discuss and with the client and decide either monitoring or treating it. Okay, so we said if lesion is exposed to the oral cavity, we need to treat the tooth. And then how do we treat the tooth? We have two options. One option is extraction. And extraction is always the treatment of choice for the teeth that are showing type 1 tooth resorption. So if we clearly see the ligament around the roots, around this remnant of the distal root of M1, mesial root, both roots of P4, these teeth have to be extracted. Yeah, and then we take a post-op radiograph and confirm that alveoli were vacated. If the tooth is affected by type 2 tooth resorption, meaning that the dental tissues are being replaced by bone, radiographically no obvious signs of periodontal ligament space. So type 2 tooth resorption, and at the same time we don't see any endodontic pathology, and at the same time the animal is not showing signs of stomatitis, we can perform so-called coronectomy or crown amputation with intentional root retention. So what does this mean? Let's have a look in this case. So these tooth, we already saw this one. This canine obviously has a lesion exposed to the oral cavity, so the tooth needs treatment. Then we take a radiograph and we see that the majority of the root is actually affected by resorption, and that is type 2 tooth resorption. So by definition, this would be stage 4C, type 2 tooth resorption. We don't see any signs of endodontic disease. We can't even see the pulp anymore. There is absolutely no periapical pathology. And the cat obviously does not have stomatitis because mucosa is perfectly nice and pink from what we see and what I can tell you. So we can do crown amputation with intentional root retention. So how do we do it? We open a flap in a very same manner as we would do for extraction. And then we take usually a small round carbide burr or diamond burr, and we amputate the crown slightly below the slightly below the alveolar margin. Yeah, and then we smoothen everything so that there are no sharp edges, and suture the flap back in place. Yeah, and the flap needs to cover the whole area of the amputated root. We confirm this amputation radiographically, and ideally, we follow these patients up in 12 months. It has been shown in studies that tooth resorption, crown amputation, if performed in correctly selected cases, will lead to continuous root resorption. So it is less traumatic option, faster procedure, which will result in a good outcome. Here is one of the cases with a follow-up, for example. So at this point, I amputated basically whatever was remaining of both canine teeth. And this is the same patient 12 months later. And we see continuous resorption and resolution of the problem regarding canine teeth. And we can see that this cat eventually developed other further lesions affecting other teeth. In some cases, be very careful if you are deciding for crown amputation. And this is one of such cases. This third premolar tooth obviously was affected by tooth resorption. Mesial root looks like type 1, clear type 1 tooth resorption. Distal root, it doesn't look that clear. It may be even type 2. So what do? We would open up a flap for an extraction, so a triangular mucoperiosteal flap, remove alveolar bone like you would for an extraction over both roots. Yeah, we know already radiographically that we have to remove the mesial root. And what we do with the distal, we actually look clinically if we can actually see the tooth there. And eventually, even the distal root, this is the distal root, yes, it was partially resorbed, but then the apex, as you can also see it radiographically, was intact. So this needs to come out. Yeah, and then confirm complete removal of the tooth also radiographically. It is unacceptable to perform crown amputation with intentional root retention on type 1 lesions. If we see periodontal ligaments space radiographically, we have to remove the teeth. The reason why is because if we don't, these roots will act as foreign bodies and will continue to cause problems and will act as foreign bodies. Yeah. So we can see this case. This cat came to us a few weeks after crown amputations when dental radiographs were not performed. So it was blind crown amputation, which is absolutely not acceptable. And the cat didn't do well after these coronectomies, didn't heal well, the tissues were inflamed, the cat was painful. So we decided to radiograph the animal, the dentition, and what we saw is that crown amputation was actually performed on type 1 tooth resorption lesions, and that is not acceptable. These roots will never resorb. What do we do with type 3? Well, it's now that we know how we deal with type 1 and type 2, we know how to deal with type 3 as well. So if, let's say, like in this case, distal root is affected by type 1, mesial root is affected by type 2, tooth resorption, we will extract the distal root and perform crown amputation with intentional root retention on the mesial root. So nothing very exciting here. The other thing is that I'm now straying a bit, is resorption in endodontic disease. So endodontic disease is an inflammatory process related to the dental pulp. And what happens here is that once the tooth becomes non-vital and the inflammatory process establishes at the root apex, this can lead to activation of odontoclasts in the periapical periodontal ligament, leading to inflammatory root resorption. Yeah, so we clearly know what the etiology here is. It's the inflammatory process from endodontic disease that is causing apical inflammatory resorption. Why do we know that this tooth is affected by inflammatory root resorption? Look at the root's length. Yeah, the fractured tooth appears radiographically shorter compared to the contralateral healthy canine tooth, and this shortness is due to apical root resorption. Okay, so this is what concerns what we know, not really much, but what we know from tooth resorption in cats. What about dogs? So tooth resorption can affect dogs as well. We just know even less about tooth resorption in dogs compared to cats. There are basically 2-3 studies out there looking at currently looking at this problem, and 2 of them are actually now 14 years old. So let's still have a look what we have available there and what we can do for these patients. So tooth resorption in dogs, as per these 2 studies, is actually relatively common. We said that tooth resorption affects 30 to 70% of domestic cats. If we look at dogs, well, it's half of the dogs that it's affected as well. And it's probably still likely underestimated because of the limitations that we have with dental radiography. Usually it will affect older, bigger dogs. For some reason that is unknown, it is more common in neutered males. And what is also true in dogs is that several different types can actually be found in the same dog. When it comes now to classifying tooth resorption in dogs, I hope that will not really cause too much confusion, because tooth resorption in dogs is classified using human classification. Yeah, in cats we were talking about 5 different stages and 2, let's say 3 different types. In dogs we talk about external and internal resorption, and then external and internal are further subclassified depending on the mostly radiographic appearance of the lesion, especially its appearance and also location on the root. So what are these classes, or what are the types in dogs? The first type is external surface resorption. So what we see, we can't see this lesion clinically. It's something that we will note on radiographs. And on the radiograph, what we will see is this kind of indentation in the root, which is filled, and the defect is filled in with bone, and there is still periodontal ligament space visible. So this would be external surface resorption. It only affects about 5% of animals, and its etiology and significance, it's not really known. In humans, it is considered to be self-limiting, and it's usually just sitting there. So on the other hand, though, it may represent an early stage of replacement resorption, which I will discuss shortly. So what do we do with external surface resorption? Not much. It's not exposed to the oral cavity. It doesn't look to be associated with any inflammation. So we would just let the client know, make the note of it, and monitor it probably within 12 months when it's the next regular appointment for this patient. External replacement resorption could be, let's say, or maybe even the same entity as type 2 tooth resorption in cats. What we see radiographically is literally replacement of the dental structure with bone, and periodontal ligament becomes less and less obvious. This actually is pretty commonly identified or diagnosed in dogs. It affects about 1/3 of dogs, and it's usually affecting older dogs. And regarding these older dogs, usually the maxillary first premolar tooth is commonly affected. Again, it's something that, as long as it's limited on the root, it is considered non-painful. We don't really know the significance of it. So if it's not exposed to the oral cavity, again, we would just monitor it. We have absolutely no idea how fast disease progresses, similar to cats. So probably we would recommend 6 to 12 months radiographic recheck, or as needed if the disease becomes obvious clinically before that. The problem is that if this lesion is exposed to the oral cavity, or let's say this tooth is fractured and needs to be treated, then these teeth need to be removed, and extraction of teeth with replacement resorption are usually extremely difficult, challenging, and may sometimes need to be combined with, for example, piezo surgery. This is one of the cases, and probably you've seen that before if you are working quite a bit in veterinary dentistry. You can clearly see that these third and fourth premolar on the mandible are resorbed, and part of the tooth is actually replacement resorption. But then again, we can still see these obvious root tips with pretty clear periodontal ligament, possibly also some periapical periodontal ligament space widening, which is suggestive or can be suggestive of endodontic pathology. So these teeth need to, or these remnants of teeth, roots, need to be removed. And this is very, very challenging. You can see here that it's very easy to stray, to misguide yourself, starting causing even problems to adjacent healthy teeth. And these little root tips, which are lying basically just above the mandibular canal, are also prone to be pushed or can slip into the mandibular canal. So these indeed are absolutely challenging extractions. External inflammatory resorption, this by definition needs to be treated because it's associated with inflammation. And this inflammation can derive from periodontitis, like in this upper case, we can see total loss of attachment and associated inflammatory root resorption. Also, and that is usually in 50% of cases with external inflammatory resorption. About 40% of cases are associated with endodontic disease, so pulp diseases. By definition, as we said, this needs to be treated because not only that these are exposed to the oral cavity, they are also inflammatory in nature. What are the treatment options? Absolutely extractions, especially in severely or especially in advanced cases of periodontitis and root resorption. Endodontically affected teeth can obviously also be extracted, or endodontic treatment can be performed as a measure to control inflammatory, external inflammatory resorption. Here is a case where we treated the patient by endodontic treatment. So we can see again external inflammatory resorption of this left mandibular canine, and we address this with endodontic treatment. Yes, there was some leakage of the sealer through the apical delta, but this is still considered relatively minor leakage and does not lead to, it does not mean that this will be a failure. External cervical root surface resorption is a type of resorption that starts somewhere at the cement-to-enamel junction, and then it spreads on the crown and on the root. Again, by definition, because it's exposed to the oral cavity, we can see the lesion. The tooth needs to be treated, and the treatment of choice is extraction. Then internal types of resorption, internal inflammatory resorption. This is evident as a widening, let's say localized widening of pulp chamber due to inflamed pulp. This tooth is fractured. We can see a fracture of the crown here. And this lesion is considered internal inflammatory resorption due to inflammation of the pulp and this inflammatory process activating odontoclasts. The treatment here, again, we have to address the underlying problem. So this is mostly endodontic disease. It can also be periodontal disease if it's severe. So if it's severe periodontal disease, then obviously we will extract the tooth. If it's purely endodontal disease, then we may consider endodontic treatment, although treatment of such abnormally shaped canals can be extremely challenging. Internal surface resorption, this one is very difficult to diagnose. By definition, this is an oval-shaped enlargement of the root canal in the very apical third of the tooth, in an otherwise periodontally and endodontally healthy tooth. It's rare and it's considered self-limiting in humans. The fact is that it's very, very difficult to discern it from internal inflammatory resorption. So therefore, that may be a challenging one to decide if it needs or not treatment. And then the last one would be internal tunneling resorption. This one actually appears as a hollow tooth. We can still clearly see the ligament space around the roots, but the majority of the inside of the tooth is literally gone. By definition, again, if it's exposed to the oral cavity, it has to be treated. Treatment, obviously, in such advanced cases, it's extraction. And extractions then can be very, very challenging because these roots are very, very brittle, crumbly, and like to fracture during the extraction process. And then in a study when they were looking at comparison of classification between human and canine tooth resorption, they also found out that canine tooth resorption in about 8% of animals cannot be classified using this human classification. And those were cases that had all different weird types of resorption, such as internal resorption, external inflammatory replacement resorption. So very unusual combination of resorptions, and these were normally or usually associated with either previous radiotherapy or dentigere assist. Why? There is no clear answer. And with this, I would like to thank you all for your attendance of this webinar. And if there are any questions, I'm happy to take them.
Yeah, I see someone ask a question. Dr. Anna, if you can answer.
How cats can complete their life normally after amputation, probably. As soon as we take away pain, which is related to these lesions being exposed to the oral cavity, cats and dogs will do much better. And especially domestic cats and dogs that we feed, that we take care of, not really need their teeth for eating. We don't really need to even adjust their diets a lot. Without pain, cats and dogs will also be able to chew on some smaller food. Obviously, they can't really eat big pieces, but definitely they can live normal and happy lives without pain after extraction or amputation of the teeth. Is it true that cats have just 4x4 teeth with chewing area? And this is an interesting one. If we look at the cat dentition, there really is no chewing area. There is, their teeth are not having really occlusal surfaces. If we look at the dogs will have some occlusal surface with maxillary molar teeth and mandibular molar teeth. So that would be truly chewing area. Cats are more, they are more carnivorous compared to dogs, and their dentition is meant for cutting. So they don't really have that chewing area as we would understand chewing. They mostly cut the food rather than chew. This is an interesting one. Well, what antibiotic do you recommend for dental disease? Well, this is a whole lecture per se. None. I don't recommend using antibiotics for dental disease at all. That's very, very specific cases that would need antibiotics during the procedure. And then there are even less cases that would need antibiotics after the procedure. And these are mostly related to osteomyelitis, severe osteomyelitis, generalized or periodontal trauma or open jaw fractures. But for regular, let's say regular dental disease, periodontal disease, dental fractures, tooth resorption, no antibiotics are really recommended. Are there significant sex difference in the occurrence of TR in dogs and cats? In cats, not. In dogs, males are predisposed for whatever reason. We don't know really. Okay, what medications would you typically give to manage pain during tooth resorption? Non-steroidals. So meloxicam is the drug of choice. If it's not I mean, if there are no systemic contraindications to the use of it, and usually there are not that many. By various means, not sure what that relates to. But yeah, so the first drug of the first choice is non-steroidals, and the second one is an adjunct. If we believe that non-steroidals are not enough, are opioids. How you will clarify tooth resorption to pet parents, in particular of serious case. So I normally have, you know, some, even if you look on my website, I have clinical images and dental radiographs of previous cases available so that I can discuss how it looks, so that they understand how severely the tooth is affected before actually we even do the procedure. And if their pet would indeed suffer from tooth resorption, I will show them the radiographs and clinical images of their own animal, looking together as what is there. And the way I would clarify it is very similar to what I was telling in this lecture, that this is an enigmatic disease where this resorption process that is normal in deciduous teeth will now affect permanent teeth, which is abnormal. Teeth cannot just fall out when they are permanent, and that is a source of pain, and that's why we want to address that. And then it takes time that, you know, the word of mouth goes around that patients are doing better. Majority of the patients are doing better after we treated dental disease. And with time, more and more clients will understand the importance, also with the experience that they share, with the experience that they have with their own animals, they will understand the importance of the health of the oral cavity. Can we perform PBM therapy? I'm not sure I know what is PBM. If you can just type out that shortening, I can maybe answer. Do you have information about the relationship between periodontal disease and insufficiency of kidney in cats? There was, I think, 2022, a study came out looking at risk of chronic kidney disease in cats with periodontal disease, and there was an association found, and that's it. There is still no cause and effect relationship, but it was found that cats with periodontal disease had an increased risk for developing chronic kidney disease. Why and what is the relationship? We don't really know as a profession yet.
Okay, so what's more?
Photobiomodulation. I honestly have no experience with photobiomodulation therapy after extractions or after any type of oral surgery. We would normally just prescribe these patients with pain medications and anti-inflammatories, so pretty standard conservative therapy. Yeah. So I can't really comment on that from experience.
Okay, so we are waiting for the last minute. If anyone else still have any questions. Okay, very nice. So I guess everyone understand where this speech. So let's skip this page to next. Okay, so I will make a brief introduction about our dental unit. For the moment, we have two types of dental unit, DU2000 for the economic one and the D Pro for the high-end one. Our DU2000 with high-speed handpiece, low-speed handpiece, three-way air water syringe, and scaler, 4-in-1. And for D Pro, it will have all function of the DU2000 and additionally with a suction system. And the scaler is a separate with the machine with an independent pedal as well. The air tank made by the Thomas and the handpiece made by NSK with better quality to use and with more, as you can see, with more pedal control to make it more flexible to use. With more detail for your reference, you can check this page. Automatic drain system to avoid some trouble of daily maintenance. And oil-free compressor also with the magnetic holder. For more detail, you can see in this page. Okay, and so if you have any more interest, you can feel free to contact with us. And thank you everyone for participating in this event. Hope to see you soon.